afternoon and welcome to post-lunch session, the historic first NRS conference, and I'll be presenting to you COPD guidelines 2023. What are changes made? And as you know, COPD is the most common non-communicable disease in Nepal. So my talk will be based on these gold guidelines only. You can freely scan these guidelines on Gold website. You can download all those literatures. I do not have any conflict of interest. So what are the changes? My objective for today is you should be able to properly categorize COPD patients. You should know ABE grouping and then learning how to treat them approach. So basic information, COPD is the third most common cause of death globally. And 90% of deaths are in low and middle income countries like ours, and it is the seventh most common leading cause of disability. And if your patient walks less than 100 meters, 5-year mortality is 30%. Alright? So earlier days it was said that COPD is a self-inflicted disease in genetically susceptible individual. And this Fletter and Peter Crown, what does it show? That at the age of 25, everyone, regardless of his event during childhood, has 100% of his lung function, which do not exist true today, because there are other studies that are showing that there are various events that will impair your lung function in the adulthood. So biomass exposure, not only tobacco smoking, biomass, occupation or genetic, even childhood infections are very important markers. So they say everyone in different age group will have different lung function, and based on the their risk factors, lung will perform accordingly. This slide is saying where are we lacking? Pulmonologists today, why are we lacking? Why COPD is still a threat? Look at this chart on the left. Cardiovascular mortality has decreased significantly. Similarly, cancer mortality is somewhat stable. Stroke, cerebrovascular mortality has decreased, but COPD mortality, see, it is increasing. So, is there problem with us, or is there problem with lack of interest in COPD patients? So, this is something we all should be careful of. Now, this is just, I told you, they are proposed new taxonomy based on etiology. So, COPD, because of various risk factors, is classified according to this. So how do you diagnose COPD? Any individual with dyspnea, then cough and sputum with risk factors like your cigarette smoking or your biomass exposure, childhood infections, recurrent childhood lung infections or occupation. If they come to you, you do a spirometry, and if you are able to document obstruction, that is FEV1 and FVC post bronchodilator less than 70%, you will label him or her as a COPD patient. So this is the latest proposed guidelines. So what changes you are seeing here is now ABCD grouping has been scrapped. So C and D has been scrapped and it is merged into group E. So group E stands for more exacerbation. So lower you will see A and B, all it is divided based on symptoms. So only symptom and low risk of exacerbation. But group E, regardless of symptom, you have more exacerbation. Even 2 exacerbation or single leading to hospitalization will be categorized as group E. Earlier in previous guideline it was ABCD, you all know. So 2 scoring systems were used, MMRC grading for dyspnea and CAT scoring. I think MMRC you all are aware of. And then CAT scoring is 8 questionnaires. Each questionnaire has a point 0 to 5, so maximum point 1 can get is 40, and more than 10 is significant. So this is MMRC grading, and this is CAT scoring. So if you have more than 10, it is significant. Second thing is, if you have classified, your patient may ask you mortality or prognosis. So if you do BOD index, so BOD index will document you BMI, obstruction, 6-minute walk distance and FEV1. So if you have maximum point that you will get is 10. If you have a score more than 7, 2-year mortality is very high, 30%. If your score is 5 to 6, 2-year mortality is 15%. But in city like Kathmandu or any metropolitan city wherein you have a limited space, you will not be able to perform 6-minute walk distance because you need a 30-meter distance. So in that case, ATO scoring is equally good. So this is previously treatment guidelines. So A, B, C, D. Group A, earlier it was said you give a bronchodilator and they have no preference for either short acting or long acting. But now they are saying you can give either, but preference is for long acting. That could be either LABA or LAMA. Group B, they said earlier you start with LABA or LAMA, but now they are saying you add, not or. LABA plus LAMA should be given because two drugs with different mechanism of action will have a better effect compared to single drugs. And then C and D, they merged it into single, leading to E. So if you have patient in this group, we will be treating accordingly. And I have divided my talk, second half will be on cases. So we'll see how to, goal of treatment will be to reduce symptom, to reduce exacerbation, mortality. So for all cases following onwards is this, and aside from pharmacological management, you have a talk on vaccination, pulmonary rehabilitation, smoking cessation. This should be advised to all. For group A, you will have, we'll see all cases, and proper treatment is mandatory. Now case 1, let's see, 52-year-old female smoker, breathless on horizontal level ground, cough on and off for past 2 years, scanty sputum, CAT score is 9. She was taking cough syrup, antibiotics, and then her FEV1 FBC is obstructive, so less than 70%. There is obstruction, FEV1 is also less, so there is moderate obstruction, 65%. Blood eosinophil count was normal. So where does this patient lie? Diagnosis is COPD, there is obstruction already. She is a smoker. Gold group. Group is 2 because 50 to 70 is, 79 is group 2. And then, gold 2, and group is no exacerbation, less symptoms, less than 10, so group A. This patient is gold 2, group A. So how will you treat? If you see gold A, I told you earlier that treatment is either LABA or LAMA is preferred, not plus. So any of the two will do. But if their symptoms are very infrequent, you can use it on a SOS as required basis also. Or you can use short acting as well, but daily short acting is not required. It was seen in a study that if you give short acting bronchodilators daily versus only when required, the results are there is no significant changes. And again, two groups are recommended here also. If you give SAMA plus SAMA, better outcome is there. So again, this is repetition, just same thing. Aside from pharmacology, smoking cessation, lifestyle, all these things should be. For group A, smoking cessation, physical activity, and vaccination. So you have a very nice talk pre-lunch about vaccination. Next case, 58-year-old male smoker, 40 packs here, walking more than 100 meters. He or she is breathless and had one acute attack leading to hospitalization. So hospitalization directly, no, nothing to think. Group E. So when group E, our treatment will differ. He has various comorbidities, and then symptom is also, burden is high, MMRC is 3, CAT score is 22, there is obstruction, and in this case you have a higher eosinophil count also. So in this group, patient falls in group E, and then scoring your gold group category is 2. So treatment will fall on LABA LAMA. Whether should you give ICS or not? Yes, you should definitely give ICS because your eosinophil count is more than 300. Second indication for giving ICS is more than 2 exacerbations. So these are absolute indication for giving ICS or history of asthma. So we'll be using LABA, LAMA plus ICS in this group. Aside from that, all those intervention is required. Nutrition. BMI was less, so nutrition, Hippocrates once said that let food be the medicine. So nutrition in COPD patient is very important, and you should not disregard, because see, body index you saw, if your BMI is less than 21, it will also increase your mortality. And then COPD patients are prone to have more catabolism, more catalectic. So it is not that you should be adding nutrition, but balanced diet is good enough. Theoretically, high calorie diet is required for them, high fat diet, especially fat protein, because of low CO2 production. It is also seen that 25 to 40% of patients with COPD have evidence of nutritional deficiency. So you should give proper suggestion. Now, see, earlier what you know is only smoking cessation and oxygen improves mortality. But there are two studies, ETHOS and IMPACT trial, that says cryotherapy. So ICS, LABA, LAMA will improve mortality also. All-cause mortality will be beneficial aside from decreasing exacerbation. So this was published in Blue Journal saying that all-cause mortality will be lesser in patients taking all these three combined rather than taking either two in any combination. And this is same power, they just change the molecule. Cryotherapy is better, has mortality benefit also. So for group B and E, aside from smoking cessation, pulmonary rehabilitation is important, exercise and vaccination is also important. Now group 3, 62-year-old female, biomass exposure, breathless, walking up the stairs, no exacerbation in last year. Okay, she is on LABA ICS. She is on LABA ICS. So CAT score is high, 25. MMRC is less. Obstruction is there. FEV1 is severe. There is severe obstruction, and eosinophil count is low. So is it just that you will change the management? No. See, eosinophil is less. So first thing is you should remove ICS. There is no exacerbation in the last year. And with every time you encounter COPD patients, always check how the technique, whether they are taking it properly or not, whether they are adherent to the therapy or not. Alright. So she had a poor inhaler technique, so it was taught, and then ICS was removed, should be removed, and ICS plus LABA will be prescribed because she is gold group B. And gold group B, I told you, as per the recent guidelines, should be LABA plus LAMA, not LABA or LAMA, and then you had which was earlier. And so she is not an exacerbator, so she falls in dyspnea group. So dyspnea, you started LABA LAMA still, then you have to check adherence on when the techniques. You can change device also. So see, giving steroid is a norm, but you should know that just because you have a hammer, you cannot hit all types of nail. Alright, because hitting on a bent nail will not meet your purpose. So when and if indicated, you must use steroid, otherwise there is no room. Fourth case, 58-year-old male, 30-pack smoker, and has to stop, so MMRC is 2, and she is a frequent smoker, frequent exacerbator, 2 exacerbation in last 12 months, means group E. She is on group E, already on LABA LAMA, so that's fine. Her CAT score symptom is very high. She has a moderate obstruction and eosinophil count is 220. So less than 100, no need. More than 300, definitely use. In between 100 to 300, if you have exacerbation, you should use steroids. And she has good in her technique. So group E, you give an steroid, still exacerbation is there. What you should do, you should add. If she is a former smoker, see, active smoker, you should not be giving azithromycin. Former smoker, azithromycin is seen to be helpful. So in this group, exacerbator, you add LABA LAMA ICS plus azithromycin for 1 year, 250 mg daily for 1 year, or 500 alternate day for a year. So, but then again you have to side benefit and risk side should be outweighed. I think last case, 57-year-old male smoker, 35 year, BMI is high, chronic productive sputum, breathless, no history of asthma, LABA LAMA. Her ratio is 0.75. What is this? So she do not have obstruction. She do not meet the diagnostic criteria for COPD. Alright. But our FEV1 is mildly decreased. Our eosinophil count is perfect, good inhaler technique, still symptomatic. So this is pre-COPD. What is pre-COPD? Pre-COPD is anyone with preserved ratio, like cardiologists say preserved ejection fraction. So preserved ratio, but symptomatic with or without structural and functional impairment is pre-COPD. And for pre-COPD, earlier days it was seen that 30 to 40% of the population physician prescribe bronchodilators. But now recently there is a study that says there is no role of bronchodilator in this group of patients. So what should you do? Leave your patients with symptoms? Go and enjoy, that's your fate? No, we can't do that. So you should ask them to quit smoking, stop smoking, encourage exercise. That's what you can advise them. Okay, so that's what it is. Now, alpha-1 antitrypsin deficiency, it is, some guidelines say all patients with COPD should be recommended. But what you can do is, in geographic area wherein alpha-1 antitrypsin deficiency is there, you can, and there is emphysema in early age, less than 45, emphysema of the lower lobes, bronchial cases, or there is CN positive vasculitis. In this subset of patients, you can check for alpha-1 antitrypsin. And if there is deficiency, you can augment it. Antitussive, Norol's, vasodilators, Norol, methylxanthine. This is also called poor patients bronchodilator, like aspirin. So, they are, if unaffordable, yes, it can be given. It also potentiates the effect of ICS. Okay, and then, but it should be given with LAMA. Okay, and then no single, only you cannot just prescribe, not indicated, unless he or she cannot afford to buy expensive medicines. Antioxidant mucolytics, yes, in a selected group of patients who are not chronic bronchitis, not on steroid, inhaled steroid, you can use them, and they are supposed to decrease your exacerbations as well. Roflumilast, unfortunately not available in Nepal. 2 local companies are making it. Maybe in few years or month it will be available to us. That is phosphodiesterase 4. And biologics, we have biologics but not available in Nepal. They are also supposed to decrease exacerbation. The 2 biologics used are mepolizumab and benralizumab. They are both IL-5 and IL-5 receptor antagonists. Also IL-33 antagonist in phase 2 trial is there. So opiates, if your patient, you have tried everything, still dyspneic, you can use opiates. That could be oral or IV to reduce symptoms, because dignified exist. I remember Dr. Subodh who always say your patient should die with dignity. He should not, or he or she should not die because of pain or because of his illness, with crying on the bed because of dyspnea or craving for oxygen. So dignified exit should be there. In such cases, you should use opiates. There are interventional therapy not available in Nepal, and this only, even if it is available, it will only target few people. So no need to worry about it. Various bronchoscopy and surgical options are available. So conclusion, smoking cessation, vaccination, pulmonary rehab, AB grouping. You should focus on AB grouping. E is for exacerbation, high risk of exacerbation, and all those treatments are available, but you should focus on combination bronchodilator rather than single bronchodilator. There is misnomer in the market that steroid is out of COPD. No, it is not. And it is seen that steroids, if you compare steroid alone with single bronchodilator alone, FEV1 improvement with steroid is better than either of the product alone. And all-cause mortality is decreased with steroid, adding steroid by 40%. So thank you very much.
Thank you very much, Dr. Naveen Misra, for enlightening us on